So we will be starting with eyelid malignancy, surgical or conservative management, with Dr. Shubha, Jhavar as our speaker.
At the outset, I thank the organizers of this AIOC meeting, Kolkata, and Dr. Anashwa Ganguly for letting me present this topic on eyelid malignancy, surgery, or conservative treatment. The first slide, it's not moving, yeah.
So the timer is set on 12 minutes, it should be. Okay.
So we go on to this topic of eyelid malignancy. So once a patient like this comes to you with a small tumor mass near the medial canthus, what options do you have and what will you like to do? And in such a case with an extensive malignancy where you can see the nose is puckered and lifted up and the or the head neck size involved. So in such cases, what options do you have for treatment of these malignancies? So factors to consider will be the patient's age, any previous medical history, any present state of health of the patient, and the importance of cosmetic preservation, the patient requirements, and tumor characteristics like the number of tumors, the size of the lesion, whether the borders are well defined or not, the site of the tumor, any history of previous radiation, high or low risk characteristics of the tumor, and to this I would add socioeconomic status, which is very important in our country. Depending on this, the patient will follow up with you and come for the further treatment. So these are the utmost factors to consider the treatment of this patient. So various modes of therapy are available for this eyelid malignancies. The first and foremost would be surgery. Then you have alternative treatments like cryotherapy, external beam radiation therapy, topical chemotherapy, laser, systemic chemotherapy, photodynamic therapy, biologic therapy, and targeted therapy. So surgical management, of course, the treatment is individualized to the patient. As I told you, the factors to be considered have been labeled, and situation, the tumor characteristics, and histological subtype. So outlines for surgery will be biopsy, and generally we go on to the excisional biopsy or surgical excision. So surgical excision has to be a wide local excision. So remove the tumor along with a clear 5 millimeters margin, and you should consider intra-op margin control in the form of standard frozen section or Mohs micrographic surgery, which is a layered excision and minimizes healthy tissue sacrifice. So eyelid reconstruction is carefully considered, as both function and aesthetic outcomes are important, of course, depending on the extent of the tissue removal, site, and size of the tumor. So small defects can be closed directly with or without cantholysis. Moderate defects up to half of the lid will be closed by Tenzel's flap, and larger defects over half of the lid will need Hughes tarsoconjunctival flap or a Cutler-Baird bridge flap. Or you can use Mustardi's cheek rotation flap, and the recent ESOPRIS learnings, Richard Allen has proposed composite lid flap from the other lid. So defects less than 50%, as I told you. So this was a case that came to me with a sebaceous gland carcinoma, looked like on the upper lid, and therein we went ahead for wide local excision and a Tenzel flap reconstruction, and you can see the tumor was excised well and reconstructed very well. So another such a large mass covering almost the 3/4 of the upper lid with an ulcerative growth. For her, we went ahead with Cutler-Baird technique, wherein we resected the tumor and made a bridge flap from the lower lid in the first stage, and the second stage we cut it and upper lid healed nicely with good lid movements. This was another case with an ulcerative growth at the near the lateral canthus in the lower lid, the lateral part, and for him we went ahead with a Mustardi's cheek rotation flap, wherein the reconstruction was done very well. This was another very huge mass involving the complete lower lid, the medial canthus, the medial part of the upper lid, wherein it was excised completely to leave a very large defect which was covered with Mustardi's cheek rotation and a glabellar flap. So here now with this very large tumor, we can consider neoadjuvant chemotherapy, but for this case, the lady had come after 10 years of her taking care of this tumor at home, and now once she comes to me, I had no other option but to go in for direct excision and reconstruction. So these are the factors that need to be considered. Orbital invasion here in extensive cases, we have to go for exentrations. So in such a case, so cryotherapy is another modality of treatment, but it is used rarely because of high rate of recurrence. Then radiotherapy, yes, of course, it is curative and it can be used as an adjuvant to surgical excision or palliative in advanced and extended lesions where surgery is not suitable or the patient is not fit for surgery, where we can give around 50 to 74 grays of external beam radiotherapy. Now this minimizes the need for reconstruction, so you can give it before surgery. It can be used for removal of recurrent tumors and extensive tumors, again, that cannot be adequately removed. And in frail patients who are surgically unfit. In sebaceous gland carcinomas, these can be used to shrink the tumor before surgery, and those who are spreading locally or into the orbital bone, again, you can use them. And in large, very large basal cell carcinomas where the margin is positive and perineural invasion is there. So adverse effects, of course, are there: keratinization and loss of lashes, necrosis, telangiectasia, and ectropion formation, and irradiated tissues show poor healing, so the future treatment is difficult. So then we have topical chemotherapy where 5-FU or mitomycin C can be used. Now 5-FU in the form of Effudex skin cream is used twice a day, and for this then you have redness and pain and sensitivity to light. So this can be used in sebaceous gland carcinomas with pagetoid invasions, and for this you can also use topical mitomycin C, which is rampantly used here, 0.04% 4 times a day with weekly offs. Then laser therapies can be used, and my skin colleagues have been using this, and for small tumors, so CO2 and argon or Nd:YAG laser can be used. Then you have neoadjuvant chemotherapy, which is, as I told you, being used in aggressive sebaceous gland carcinomas. So cisplatin, doxorubicin, 5-FU, and mitomycin C can be used. Now, courtesy and Ashua, this is a slide she has shared with me. And this patient was treated in LVPI, a 46-year-old male with extensive sebaceous gland carcinoma, where a spontaneous resolution was possible after giving him systemic chemotherapy. So this was an extensive case wherein the adnexa and the orbit was involved. So neoadjuvant chemotherapy with cisplatin and 5-FU were given for 6 cycles, and chemo reduction, that is 60 to 75%, you can see here in the other pictures, where they helped in performing the conservative surgery in extensive sebaceous gland carcinoma. So of course you should go ahead with such treatment. Then you have biologic therapy, that is biologic agents like imiquimod, used in superficial basal cell carcinomas, but the patient needs requires monitoring for possible recurrences from buried tumor cells under the skin. So imiquimod is used as 5% cream for nodular basal cell carcinoma. This is an OD application 5 times per week, and it has to go on for many days because recurrences have been reported, but the lesions less than 10 millimeters are said to give 100% cure. Yeah. So this paper has shown that 81.8% of tumors more than 10 millimeters give a 3 years histological clearance. So then targeted therapies there, where drugs which target the tumor cells by specific cell cycloantigens to disrupt the tumor cell growth and division. are used here to treat some cases of advanced or metastatic basal cell tumors which are not suited for any other conventional treatment option. So Bismo they give is available. This is a hedgehog pathway inhibitor to treat basal cell nevus syndrome or Gorlin syndrome, where numerous cutaneous lesions on the face and periocular region are seen. And this is used for locally advanced or metastatic basal cell carcinomas or in relapses. This reduces the size of the tumor and has to be given orally 150 milligrams per day for months. But resistance is of course a challenge, and we don't get this here. That's why we are not using it. So let's hope we get to use this in the near future. These are my references. Thank you so much.
So thank you, Dr. Jhavar, for nicely elucidating all the treatment modalities available for treating eyelid